Elise, I think, mentioned to you that the resident accounts, for some reason, we can't start recordings.
Okay.
So we either need like an admin link or something like that, because all like clinic can't select who's there for a meeting.
That's what I heard. Yeah, we need to talk to Patience Wieland. Can get us up. I think she met with you guys once, but we need to get in touch with her. I don't know who the best person is, resident, to make contact, but the Grand Rounds Monitor. Yeah, perfect. That's Elise right now? Okay, so we'll have her touch base and make sure one of you guys has it. I mean, I guess we could just put all of you guys with that, because as your Grand Rounds moderator or whatever, you can have it available. I doubt you guys will be superfluously making lectures. But, okay, I have not a good place to. Yeah, just, you never know when you're going to want to post a Blackboard lecture. Okay, I hope this is not too close. It looks like it's showing good sound quality on my view here. So for those who are going to be watching this later, we're doing the glaucoma lecture November 9th, and I have the PowerPoints listed here. So I was talking with the people who are here live right now about access to the quizzes, the pretest, and I wanted to make sure people are able to access it. If you're having trouble accessing it, let me know. And I was mentioning you can download a free Blackboard mobile app through your iPhone or Android, whatever you have. So if you want details on that, ask me. And we'll get started. So about 4 of you completed the pretest in the time that it was allowed. And again, I'm closing it before so that I have time to review and get analysis on what you guys missed, what you got right, and then I can kind of gear the lecture today based on that. So that's the reasoning behind it. I'm not trying to punish people for being late. I just want to be able to have the data so I can look at it. So please make every effort to finish it before the closing time, and I think it just benefits everyone to do that so we can focus on what needs to be focused on and not spend too much time on things that everyone knows. Okay. So John was very helpful and sent me a list of what the topics were covered on the OCAP review session this week that you guys had. So I am kind of focusing on those topics. Within those topics, I can't cover everything that you guys went over in an hour, but he suggested that kind of going over glaucoma studies, the clinical trials, talking a little bit about angle recession. He thought was kind of a difficult concept, so we'll talk a little bit about that. And then I'll go over some of the other secondary open angle glaucomas, which were covered in your reading, I think, for OCAP review. So that'll be the highlights, and a little bit on angle closure glaucoma, because I found on the pretest that was the question that kind of got everyone. That was probably the hardest question on the pretest, was the one concerning a secondary angle closure. So let's get started with, well, how about we start with secondary open angle glaucoma? Okay. Let me maximize this. Okay, so we can do a little pretest here. This was from when we were doing the ARS, but I don't know if we want to try that today. I didn't actually run it with that, I guess. So we can just use it as kind of a read through, and then everyone can answer. So which of the following is not considered to be a secondary open angle glaucoma? Anyone think it's number 1, pigmentary glaucoma? Hands. Number 2, Sturge-Weber associated glaucoma. Any hands? Neovascular glaucoma, number 3. Anyone think? Neovascular? Going back to number 2. Okay, number 4. Anyone think that's not? I know these are kind of confusing, the knots. So we've got 1 vote for Sturge, 2 votes for Sturge-Weber. Okay. No one else? Okay, so I'm glad we had this question because it's actually number 3. Okay, because neovascular glaucoma, what happens is it's considered a secondary angle closure because you have the abnormal vessel proliferation in the angle and then this creation of a fibrovascular membrane that grows and secondarily shuts off the angle. So it's a mechanical secondary closure of the angle. All the other ones listed are actually an open angle mechanism. Pigmentary, I think, we kind of understand that. Pigment deposition in the trabecular meshwork will secondarily clog it.
So that confuses
guess
Okay.
we're talking more about an anatomic blockage of the angle rather than the trabecular meshwork itself being occluded, because
Right.
the meshwork is occluded in the pigmentary, so that confused me.
Okay, good question. So yes, so occlusion of the TM from a deposition of material, like what happens in pseudo-X or pigmentary, that's actually considered an open angle mechanism. Angle closure refers to a secondary mechanical and or synechial closure of the angle. So neovascular glaucoma falls into that category of having this secondary kind of mechanical zipping of the angle, so to speak, versus something that clogs it, like phacolytic glaucoma, right? Those are where the macrophages come and try to eat away the debris from the released lens material, and they secondarily clog the angle. So that, again, is a secondary open angle mechanism. Is that terminology? You look confused, Harris.
Yeah, well, so for Sturge Weber, isn't it increased episcleral pressure?
It is, and that's an open angle mechanism. It's downstream from the angle. It's not really disrupting the angle itself. So that's a bit tricky, but yeah, you're right, though.
It does depend on age, right? Because if they start early, they think that maybe there's that kind of congenital glaucoma memory.
Good point.
We don't know.
You're right. This is a poorly written question. Okay, you're right. So I'm referring to kind of the more later onset, not the congenital version of Sturge Weber, but yes, that's a good point. I should have.
Trip us up on that.
Yeah.
with that question.
Ah,
A 2-year-old and 8-year-old.
that's pretty mean. Okay, so I meant later onset Sturge Weber. Okay, not your congenital mechanism, because I agree, because that's an angle abnormality itself. Okay, so hopefully once we run through some of these slides, it'll make a little more sense to you. So really the end pathology of secondary open angle glaucoma is the same as POAG, right? You're still going to get resultant optic nerve damage with the characteristic visual field deficits. So the clinical picture will look the same, but the etiology is different, and that's why you need to know what type of glaucoma, open angle glaucoma it is, because your treatment will vary based on what the mechanism is. These are just some examples of types of secondary open angle glaucoma, so keep this list in mind when you're studying or when you're answering test questions, and we'll go into more detail. This is just to list them here. How do you guys feel about pseudo-X? Do you want to talk about it in detail, or is it something you feel comfortable about, more or less? Okay, let's go quickly, because I do have a lot of slides, so that's why I want to make sure we're focusing on what we need to highlight. So, okay, so essentially you've got this deposition. No one's really sure what kind of material it is, but this fibrillar material that deposits itself throughout the anterior segment. And so what happens is if it deposits in the trabecular meshwork, it causes a secondary clogging. But there does seem to be a systemic component. It's been found in different parts of the body, the same fibrillar material. As far as we know, it doesn't cause increased mortality. And you see this, what we call the so-called Sampolisi line. And that is where you get this kind of variegated pigment deposition anterior to Schwabi. So pretty classic gonioscopic finding. And sometimes the other deposits are not so visible on exam. So sometimes it's only the gonio that might point you in that direction of diagnosis. So it's really important to do gonioscopy, again, on all your new glaucoma patients. Otherwise, you can miss things like pseudo-X. You also may see kind of a ragged, moth-eaten pupillary border, someone who doesn't dilate that well. You know, be thinking about possibly pseudo-X, especially if they're presenting with what you think is POAG, because it may actually be pseudo-X, and you want to know that if you're going to do cataract surgery on this patient, as we're going to talk about a little bit later. Kind of a classic picture. So when you see that, hopefully it should trigger you to think about pseudo-X. You've got this kind of targeted, target shape, bullseye shape of deposition of this material on the anterior lens capsule. And you've got this kind of not super well dilating pupil. Here you can't really tell the moth-eaten pupillary border, but that may be a finding. You don't see that in everyone. You can also get narrow angle. So this is a good test question. A lot of times they try to bring up, you know, it's considered a open angle, secondary open angle glaucoma, but these patients in addition can have a narrow angle, which is kind of confusing. The reason is they get this zonular kind of, is that outside? Okay, all right. Zonular weakness, and that has to do again with this over time, this deposition of the material on the zonular fibers kind of leads to them not functioning as well and becoming kind of weak. And so you get this anterior movement of the lens iris diaphragm because these zonules are not properly functioning. So you can actually look in and see a patient might look somewhat narrow. Yet you, let's say you gonia them because you're worried they look a little narrow, and then you see the sample EC line, then you can look for some of the other stigmata, and then you really want to have pseudo-X on your list of what it might be. I mentioned things about the pupil findings, and they may have phagodenesis and iridodenesis for the same reason.
Slightly on a tangent, a lot of times in TDC we could buy the initial workup,
Mhm.
one or maybe even 3 visits.
Right.
In your opinion, what is the best order to do on the initial workup? You just mentioned you do gonio right away, but a lot of times we don't know until we got it.
Yeah. Then you bring them back for gonio. And just put in your notes, suspect PXC, consider gonio at next visit, and look for sample EC line. Especially in the TDC, it's important to say what you're thinking because you may not be the person who sees them next. So make sure that doesn't fall through the cracks. But
But if we say a patient is coming in because they're a glaucoma suspect, what is your preferred division of testing, if you will?
glaucoma suspect, just generic, no other issues?
Sometimes it literally says glaucoma suspect.
Uh-huh. Oh, I think, if they're not dilated yet, then you want to do pachymetry, gonioscopy for the first visit, maybe get disc photos if that is something you guys do regularly. I know you can do it at TDC, but I'm not sure if stereo disc photos are happening all the time.
I'm having a little problem with the camera right now.
Okay.
So we're doing it right now.
Ideally, you could do that. If not, a good drawing, use the EPIC drawing function and at least denote, if you think that the nerve looks suspicious anywhere. That's something besides a cup to disc is handy, as you guys know who've rotated with me. I like to kind of describe the nerve. I think it's more helpful. Those are kind of the initial things you do. Then you'd want to do the visual field, OCT on follow-up. So that is so weird.
It's
Oh, the AC?
Yeah, it's making it.
Okay, alrighty. So often pseudo-X is monocular, but you always want to watch the other eye because it can develop the syndrome later in time. So always check both eyes, which is kind of the rule for glaucoma in general. Is always beware of examining the other eye. It does seem to be more predisposed in people of Scandinavian descent, but certainly not always the case. I have Hispanic and even African American patients floating around that have pseudo-X. So don't rule it out in someone who's not, Scandinavian. It certainly can happen. And definitely related to age, no clear link to gender, and not only about, but half of people may develop glaucoma, but not everyone with pseudo-X will have pseudo-X glaucoma. So keep that in mind as well. A person may have a perfectly normal nerve with these findings, and you just follow them over time. You can kind of label them as a glaucoma suspect because of this predilection, but you don't have to assume they're going to have it. Just watch them more closely. Okay, so this is just some of the pathogenesis, things you may need to know for testing. Oh, is it cutting off? That's weird. Wonder why it's going off the screen.
Sometimes the 3x4, and I think the elongated slides do tend to get cut.
Okay, good to know. I don't know if I need to change how I'm making my slides. It's weird. So management. Generally, you treat these patients the same way you would do for a POAG patient. You start with medical therapy. Laser trabeculoplasty works quite well in these guys, so that's definitely an option. They generally, though, have a worse prognosis than garden variety POAG. They seem to do worse when they develop glaucoma, or if they develop glaucoma. They seem to have more diurnal fluctuations and maybe less responsive to therapy. And you can do filtration surgery in these patients. Of course, same caveat if you were to do a cataract at the same time, the warnings about cataract surgery, you have to tell the patient they're at increased risk for zonular dehiscence breaks, capsular dialysis, posterior capsular tears. All those things can happen with more frequency. And the recommendations for how to deal with it kind of change over time. I think the latest recommendation is to use the CTRs, for fixation, but fixation of the IOL because you can get late decentration even if the bag stays intact. A lot of surgeons recommend with these guys that you put in a CTR even with an intact bag, okay? Because that's what's been found is that over time, because of the zonular weakness, the lens, the IOL position can shift even in an intact bag, so you can have late IOL decentration. So, oh yeah, you always leave it. It's permanent. It's just like a implant. No. They actually go in and they're meant to scaffold, your lens position. So, Yep, so always think about that. Again, even if, like I said, you have an uncomplicated cataract surgery in a pseudo-X patient, consider a CTR. Okay, I'm going a little fast, so stop me if you guys have extra questions. Okay, so we'll switch to pigmentary now. And again, this is another secondary open-angle glaucoma syndrome. You can have pigment dispersion, which doesn't always lead, again, to pigmentary glaucoma. But be very careful about watching these patients because a significant number of the dispersion patients will go on to develop the actual glaucoma. And they actually also have findings that are pretty pathognomonic on anterior segment exam. You can see the Kuchenberg spindle. Have you guys gotten to see that in patients? So it's, once you've seen it, you kind of know what it looks like. The vertical spindle pattern of endothelial corneal pigmentation. The TM has this really prominently pigmented line, and it's very uniform as opposed to pseudo-X, which is kind of patchy. You also get potentially these mid-peripheral transillumination defects. Hard to see in patients that are really thick brown irides. You may not see it in those patients. It's more common to see in the lighter eyes. So there's some good things to look for on, again, gonio and anterior segment exam if you're suspecting it. And what's the epidemiology? So your typical patients, this is again one of those testing things, young myopic males. Of course, someone can walk in who has pigmentary glaucoma who's not young, myopic, or male, but for testing you want to know that. And it commonly presents in kind of the 20 to 50-year-old range, so a little bit younger than the pseudo-X onset. In your mind, you want to kind of have a running list of comparison between those two syndromes because they tend to be compared with each other a lot, again, academically speaking, testing-wise. Even though they're different clinical syndromes, you're going to have different patients who present with those. So retinal detachment. Anyone have ideas on why it's more common in people with pigmentary glaucoma? Right. So they tend to have, and they're not hugely myopic. The typical myopic refraction is like, -4 to 6 or something. They're not -12 and they're not -1s. Usually they're kind of middle. So relatively higher risk. If you look at that, one study showed actually an incidence of 6.4%, which is pretty high compared to the general population. And then, of course, concomitant lattice and or retinal breaks. So watch these patients carefully for those issues. They can get these high fluctuations, excuse me, in IOP, which also can happen in pseudo-X. You can get IOP fluctuations for different reasons. Here it's because the pigment's depositing and temporarily kind of moving through the TM and clogging it up intermittently, especially with anything that causes pupillary dilation like exercise or stress situations. And then they often are symptomatic, whereas the PXE, the pseudo-X patients don't generally have symptoms, just kind of like more like POAG. But these guys, if they're actively releasing pigment, they may tell you when I go to exercise, my eyes start hurting, I see halos, and then when I rest, it goes away. So be aware if you get that history. So there's a picture of the Kuchenberg spindle. This one's pretty obvious. Sometimes they're subtle. And this tends to be one of the findings that fades first after someone is not as actively dispersing pigment. So especially if it's kind of an older, burned out pigmentary patient, you may not see this. So a lot of people get confused on the mechanism for pigment dispersion. So let's talk a little bit about it. It's called this reverse pupillary block configuration. So for some reason, these patients have an iris configuration where there's a concave bowing of the iris. And because of that, that iris bows backward and actually can rub with the zonules posterior to the iris. And then that pigment gets released. So then, of course, the aqueous convection currents carry the pigment forward and through the TM and et cetera. And you get all this typical dispersion with the Kuchenberg spindle. And
In the space system, is that clear iris configuration?
Exactly. So Q denotes pigmentary. Don't use Q for anything but pigmentary.
So only if you're suspecting.
Yeah.
Because I see that sometimes.
You're like, what does that mean? Yeah. Q is the posterior. Yep, exactly. Which I don't know why they picked. It's random. I don't know why Dr. Spaeth picked queer for this. QRS. Wow. That's interesting. I didn't think. Okay.
Well, why not just use R?
Yeah. I don't.
Flat's different from R, though.
Flat is for plateau.
It's regular though. It's regular.
It would still be regular with plateau, and actually it'd be S for steep. Yeah. We should ask Dr. Spaeth. Maybe I'll email him and see. And so the question kind of is, how is a peripheral iris bowed backwards? We don't. So we'll talk about the theory in a second. So this is kind of a classic mid-peripheral depigmentation of the iris, and again, it's due to that chafing of the posterior iris against the zonules as the pupil moves and contracts and dilates. That finding will generally be there a bit longer than something like the corneal deposition. But over time, that can even fade. So kind of interesting, yeah. So the theory, aqueous is moved into the anterior chamber as you start with that posteriorly bowed iris. So the aqueous is moved in against the normal pressure gradient, maybe from peripheral iris movement with the normal, accommodation of the pupil, et cetera. And then once you're in the anterior chamber with this aqueous, what happens is you kind of get this one-way valve effect between the iris and the lens. So you get this relatively higher pressure in the AC, and then the iris is, again, pushed backwards. So it's kind of chicken or the egg, what started it, but bottom line is it's an abnormal configuration of the iris, which we think is the inciting mechanism. Why people get that we don't really know. So there's potentially a genetic component of this. I know there's been a gene that's been linked to pigment dispersion, which I can't remember off the top of my head, but I think it's in your BCSC. So for some reason there might be a genetic predisposition to getting this anatomic configuration.
As a curiosity here, so that the mechanism there seems like something that would be episodic, and I know that there have been talks about doing laser peripherally to change the iris configuration, but what I saw was that wasn't necessarily curative. So if we fix the iris configuration, why is there continuing to be progression? I'm confused by that.
That's why there's controversy in whether an LPI even works. Some people will do it if they think clinically a patient is actively dispersing pigment. It's kind of one of those, well, if we do it, maybe we'll lessen this anatomic configuration, but I agree with you. I mean, I don't think it completely goes away. It's not successful in everyone. I think it's worth a try. It's a relatively low risk procedure, especially if someone's very symptomatic and they're getting these big IOP fluctuations. It can maybe help with that. But it's by no means like an accepted treatment. I think you'll get arguments from different clinicians about it.
So for that second bullet point, why does aqueous why does it have to return to the posterior chamber if it's, the pressure is higher in the anterior chamber, that's also where the drainage system is.
Yep. I think it disrupts the actual proportion of pressure doesn't sound right, but the relative pressure, right? So it changes that, and I think it causes this kind of stopgap effect. And that's why, but it eventually corrects itself, but that's why you get these high shoots of pressure episodically, and then it breaks once the pupil changes its configuration. I think the fluid, again, is allowed to kind of go back. Does that make, yeah. So, okay, so here's our point. LPIs are not proven effective, although you could, relieve the posterior bowing of the iris to a certain degree. I don't think it's definitive. And then you can also do meiotic therapy for the same reason. You keep the pupil, constricted, and then that can relieve some of the iris bowing. But most people don't like being on pylo chronically, especially young people. And no one likes to lose their accommodation at age 30-something. So probably not going to be well tolerated by most patients. Laser trabeculoplasty, yes, it can work well, but generally, especially if they're releasing pigment, it tends to, the pigment builds back up and clogs the TM again. So it's not a real good long-term solution for these guys. And you also have to remember, if you're going to do it in a PDS patient or pigmentary glaucoma patient, you want to use lower energy settings. If you leave normal settings with the amount of pigment that's in the TM, there's so much absorption of the laser that you actually can induce IOP spikes and overtreatment. So make sure you back off on the settings when you're treating them. And then, of course, you can do filtering surgery. Does anyone know why I'm saying beware of hypotony maculopathy in these patients? First of all, do you guys know about hypotony maculopathy, sort of, as a complication of glaucoma surgery? Exactly. So myopes, people with longer axial lengths, for whatever reason, we found that they tend to develop it more commonly. So you want to be careful in these guys because they tend to be myopic, younger patients. It's a risk that you want to discuss with them. Okay, so we'll shift gears to talk about lens-induced glaucomas. And remember, these are not all the lens-induced glaucomas. I'm listing the open-angle lens-induced glaucomas here. The angle closure lens-induced glaucomas we'll discuss in a different talk. So these are very testable, right? Everyone loves testing on these, even though you probably may only see 5 of these in your life if you're not a glaucoma specialist. Even then, you see it rarely. But this one is also sometimes called lens protein glaucoma, so don't get confused if you see that terminology. More commonly, phacolytic. And again, it's an open angle, secondary open angle glaucoma, inflammatory glaucoma, where you have an intact capsule, but you get this micro kind of secretion of lens proteins when you have mature, hypermature cataracts, and they seep out into the TM and cause obstruction. And then you can also get additional obstruction because the macrophages come to the TM to phagocytize the material, and then of course obstruct the TM more. So generally, it's going to be an older patient, may have a history of chronic low vision coupled with sudden pain. Okay, so you know they've had a cataract probably for a while. Then they get this acute onset of pain, red eye, and worsening vision. And so you should see a pretty typical picture of high IOP with microcystic edema. They could have inflammation in the anterior chamber, but no KP. So you know it's not an issue of like a uveitic, you know, I'm sorry, it's late and my brain is going. KP. The type of uveitic glaucoma I'm thinking of, I'm sorry. Guess what I'm thinking? No, not Posner-Schlossman. I'm sorry. Like sarcoid, what are the uveitic, what's it called? Granulomatous, thank you. Okay, so you know, don't go down that differential if you don't see. That was bad. Okay, so don't go down that differential of that if you don't see KP, because you should definitely see that if it's a uveitic glaucoma. And then you should also, of course, see a mature cataract. You may see wrinkling of the lens capsule. If you can gonio these guys, it's sometimes a poor view because of the microcystic edema. You can maybe see debris in the angle. So kind of again, this is probably the kind of view you get, but you can maybe kind of imagine you clearly don't see a clear pupil. There's just a haziness there, partly from corneal edema, but probably the cataract sitting behind there. So you need to treat it definitively, of course, with cataract extraction, but to go into an eye like that can be dangerous, potentially causing more complications. So you attempt to lower the IOP and stabilize as much as you can medically before you go in.
What happens if the pressure comes down if the cornea remains like that? How do you do
Yeah, I mean, if the cornea is like that, it probably is not a good idea to try to go in and do the cataract surgery. You're hopeful that because it's an acute rise of IOP, if you treat the IOP and it comes down decently, then the cornea should clear pretty quickly, unless they have some concomitant corneal pathology. But lens particle glaucoma. So this is a different type of, again, open angle lens induced. So this happens when you've got some disruption of the lens capsule, traumatic, iatrogenic, you know, whatever it is, but you have an actual disruption versus a phacolytic where it should be intact, at least macro level intact. So you should have some kind of history of trauma. And the severity of the glaucoma depends on how much lens material is there. And how much the inflammation is present. So IOP generally will settle down after the lens material is either absorbed or removed. So you kind of have to make a judgment call. If there's enough lens material there, you may have to go in surgically to remove it. Otherwise, you can try to treat medically to control inflammation and hope that it absorbs on its own. So this is what you'll kind of see. You can even get PAS and posterior synechiae from the inflammation that comes into the eye. So you definitely don't want to sit too long on these patients. You have to make a relatively quick call on whether you're going to go in and take it out or not. So after monitoring for a few days, you should probably be able to make your decision on what to do. So nobody will hopefully miss that. You can kind of know what your differential is if you see that chunk in the AC. So like I mentioned, you know, try to medically control to let the material absorb. Again, if there's some huge amount there in the anterior chamber, then you're probably going to have to go in surgically. You don't necessarily want to sit on it. But cycloplegic steroids to try to help minimize chance of PAS formation and control the inflammation. And you can try, again, irrigation to try to surgically remove kind of AC washout and INA. Okay, so phaco and anaphylaxis, a relatively rare entity, but this is where you might see granulomatous inflammation. This is where you would see KP. And this is, again, after some kind of trauma. surgical or otherwise, and then patients become autosensitized to the material. So these you want to treat medically, usually with steroids. If you need to control pressure with aqueous suppressants, you can do that. Again, you may see synechial formation depending on the amount of AC reaction you have. You could even see some vitritis. Any questions about that?
So this one, the difference between those two is basically just the granulomatous.
Exactly. The etiology is different, right? Because here you're actually getting an autosensitization versus just a reaction to the material. Okay, so intraocular tumors and glaucoma. So there's different mechanisms of glaucoma that can happen when you have intraocular tumors. You can get an open angle mechanism of glaucoma with direct tumor invasion of the angle. So it secondarily obstructs the TM with basically a mass growing there. Secondary intraocular hemorrhage, secondary to a tumor, which again clogs the TM. Deposition of tumor inflammatory cells or debris. All of those can lead to a secondary open angle glaucoma. Generally, you're going to look at melanomas in the uveal tract and ciliary body as the most common causes. Ocular inflammation in glaucoma. So this is sometimes an issue, and I know we had the TDC patient recently who had this. So this is something you really can run across quite a bit in your clinical practice, and you want to know how to deal with it. So when a patient has acute inflammation, uveitis, you can get a high IOP in that setting when your trabecular dysfunction exceeds the hyposecretion that's happening because of the initial inflammation. So often you'll see a patient with uveitis and the pressure will be low. But if you do see a patient with high IOP in the setting of inflammation, think of this mechanism. And the question is, a lot of times a patient will have been on steroid for some amount of time when they have the inflammation. So you wonder, well, is it the steroid use? Is this person a steroid responder? Or is it due to the active inflammation where we're not treating the inflammation and you're getting a trabeculitis and a swelling, edema, and trabecular dysfunction from the inflammation? Chronic structural damage if it's a long-term uveitic process that's been going on. So there are all these kind of competing ideas, and the problem is that the treatment's different for the different scenarios. So you really have to figure out what's happening in your particular patient when they walk in with this. So like I mentioned, there can be edema of the trabecular meshwork itself in an inflammatory setting, or the endothelial cells of the TM can be dysfunctional in the setting of inflammation. You can get this secondary blockage of the TM with fibrin and or inflammatory material and cells. You get this prostaglandin mediated, again, prostaglandins are released right in a uveitic process, and that can cause a breakdown of the blood aqueous barrier. And then you can get this potentially steroid-induced reduction in trabecular meshwork outflow. So that's, I urge you guys not to jump to that when you're seeing IOP elevation in in a uveitic patient, because generally speaking, it's not a very common phenomenon. In someone who has glaucoma, yes, think of it more commonly because people with POAG are at a higher risk of being steroid responders. But generally speaking, it's not going to be a majority of people who get steroid response. That's number one thing. Number two is, if the inflammation is not controlled and the patient's on steroids, you're not going to do that patient a service by taking away the steroid because you're worried about steroid response. The number one thing you have to do in a setting of active inflammation is treat the inflammation. So go up on the steroids, especially if they've only been on it for 2 weeks. I mean, the chance of steroid response in that situation is pretty darn low. If they've been on it for 2 months, that's maybe another story. Then I think you should put steroid-induced pressure rise higher on your list. But if they have rip-roaring inflammation, the bottom line is you still have to treat the inflammation. And if they have inflammation that's not been controlled for 2 months on steroids, they probably need some other kind of treatment, whether you go down the road of the immunosuppressives or what have you. And then you probably want to work with other specialists and look for an etiology.
How long would you say on average does it take to manifest a steroid?
Right. So the general rule of thumb is at least 2 weeks. And there's a chronological increase in the risk the longer you're on it after that. So I just want you guys to make sure you're considering these other situations, scenarios when you see active uveitis. and not jump to steroid response.
We saw him again.
Oh yeah? How's he doing?
43.
Okay. So still high. So CPC takes a while to work. He's a, I don't know what to,
We'll see him next week. Are you
I
on?
won't. I'm doing Fake Go
We'll see
Friday
him
next
next
week. Vizeri will see him next week. Okay. See what happens. So in inflammatory glaucoma, like I said, consider a workup, right? If you're seeing inflammation and high IOP in that setting, consider some of these etiologies. So make sure you're looking at the patient's medical history to see if they're at risk of or diagnosed with any of these, because these can all lead to high IOP with uveitis. Particularly the herpes virus can cause a trabeculitis. It's, again, a testable question, herpes zoster in particular. So if you see high IOP, uveitis, on a test question, think of zoster. In the clinic, of course, look at the patient's clinical history and see if it makes sense. And these other entities, you know, in the pediatric population, think of JRA. Adult population, not as common to just get. You'd have other probably findings of rheumatoid arthritis than just high IOP and uveitis, but you can think about it and do the testing. Basically, the HLA workup, the uveitis workup makes sense in these patients. Because if it is something that has a systemic component, that needs to be treated to try to help with the uveitis. So the bottom two to consider as well that are more eye-centered issues are the, you guys mentioned glaucomatous cyclitic crisis or Posner-Schlossman syndrome, and then Fuchs heterochromic iridocyclitis. And I believe we talk about those in more detail. Let me see. Yeah, okay. Posner-Schlossman, not a very common syndrome, but it can be seen, and it has a very particular kind of presentation. So again, this is a diagnosis not to jump to. Make sure that you're considering other etiologies for having high IOP before thinking of this one. So AC inflammation, but it's not rip-roaring. It's very low grade. You might see a few small KP. But these guys they know exactly what's happening. These patients are the ones who come into you and they keep their bottle of, you know, Timolol and their steroid, and they start treating themselves before they come in once they've been diagnosed. Because they're like, I knew it was happening. I could feel it coming on. And they get sometimes pressure into the 50s. You know, they get very high IOP spikes. And it's usually unilateral. You can even have KP that on the TM if you do gonio sometimes. So it's a trabeculitis picture. Questionable relationship to prostaglandin-mediated mechanism or herpes simplex association. And you treat these guys on an episodic basis with, again, steroids and some aqueous suppression. And they usually respond pretty well to the medication when they have their bouts. But they can actually get, you know, significant glaucomatous damage over time. So they definitely need to be watched and controlled appropriately. Okay, Fuchs heterochromic iridocyclitis, again, they love to test on this. It's pretty rare. In real life, you may never see one of these, but it's characterized with this typical heterochromia. And in a brown-eyed patient, which is the affected eye, the lighter iris or the darker iris? You sure? Okay. So did I say it right? In a light-eyed patient, did I say, or a dark-eyed patient? Okay, sorry, in a light-eyed patient, which one's the affected eye? Okay, good. So you guys know that what happens is the iris pigment epithelium underneath is what basically is left when you get this heterochromia, and so a lighter eye will appear to be the dark one. But you're right, with the darker irides, it's opposite. Good. I don't remember having seen, I think I know who you're talking about, but I haven't seen him in a while. I don't know where he went. Yeah. Yeah, so again, pretty rare, but we have a few floating around. You get this mild, again, anterior uveitis. It shouldn't be a huge amount of inflammation when you see these guys. And they develop these typical posterior subcapsular cataracts, and only about 15% of these patients develop a secondary open-angle glaucoma. So again, follow them, watch them with inflammation, but it's not guaranteed that they'll get glaucoma. Small stellate KP is kind of the buzz description for the KP. You get this kind of unilateral, again, presentation as opposed to open-angle glaucoma, or more commonly bilateral. And it's kind of equal gender predilection, so male, female.
This, I have a patient I've consulted for other reasons, like papilloma, but mid-40s, 40s, female. She tells me she has a family history of different eye colors, and she thinks her left eye has been progressively changing color. It's more brown in the left eye than in the right eye.
Mm-hmm.
Is this story specific for Fuchs? Like, otherwise she doesn't have nerve changes. I'm not seeing EC reaction.
Right.
But
I don't think, and as far as I know, there's not a genetic component to this, so I'm not sure I would say that it would be running in families that way. Maybe they have heterochromia for another reason.
sure.
Don't know.
No.
She said it's like adult onset.
Yeah, she said the left eye has been changing color more in the last like 5 years.
Did you ask for a picture?
No.
Has to see like her driver's license. She
Mhm.
just be a match.
I mean, I definitely had a follow up outpatient.
Yeah, that's interesting.
Kind of like mid-life or whatever, so this case will bring five from that kind of variation, depending on
Yeah. Yeah, I don't. That's not a typical presentation as far as I'm aware.
But it sounds like the glaucoma component is less common, even if you have the rest of the picture.
Exactly. It doesn't guarantee you. It's like I said, it's about 15% incidence with Fuchs. So you do get these kind of fine vessels that run across the TM, but they don't usually cause any issues in terms of angle closure, PAS formation, and these vessels are very fragile. So this patient may come to you for cataract surgery. They have a PSC, for example. If you don't do a careful gonio, or if you're not sure, you don't know that they have Fuchs, then you may get this hemorrhage during surgery. So suspect that if you're like, why did the eye just get blood in it, and you're doing a pretty normal, uncomplicated surgery, look closely for any of the other signs. It might be that. So it could be immunologically mediated. We don't really know. But when these patients do develop glaucoma, it's kind of difficult to treat. And corticosteroids, again, are not going to be, compared to Posner-Schlossman, they don't really seem to help in treating this kind of low-grade inflammation. And you probably want to use aqueous suppressants to try to control them. But
buzzword for the residents. Remember the name of that sign.
Yeah. Oh yeah, I'm sorry I didn't mention it. The filiform hemorrhage. Yeah, I don't know why they put it in tests, and so just link that with Fuchs heterochromic iridocyclitis. There's not another condition that I can think of where they use that term. So
It's sometimes called Amsler's sign, I believe.
Amsler sign. Okay.
Yeah.
What is the hemorrhage filiform?
Amsler's sign.
Mhm.
Does the hemorrhage actually have a distinct appearance?
No.
It's not necessarily that, but a lot of the times they'll give you a prompt. They'll say you have a patient that has cataract surgery, you make your main movement out of nowhere, it's just blood.
Mhm.
Usually he's got different colored iris, like
What could
what's the
be.
cause for this,
Mhm.
what's the edge background, and it's been termed Amsler sign, rotated Amsler sign.
Yeah, I should put Amsler sign in there too. I just call filiform hemorrhage.
Yeah,
God only knows why they. Yeah. Yeah, maybe we should all go and Google it. I don't know. Okay, great. I think I tried to look it up before because we had this conversation when I gave this talk before, and I don't know if we found why.
Mhm.
Yeah, no, I'm sort of I know is not worm-like, although the vessels maybe have that appearance when you do gonio, but I don't know. So we'll talk a little bit about elevated episcleral venous pressure, which we mentioned before. So you want to consider any kind of obstruction of venous outflow or arteriovenous malformations as being culprits in raising the EVP and causing a secondary open-angle glaucoma picture. And so basically it causes an open-angle glaucoma picture because the downstream outflow of aqueous after passing through the TM is hindered because of the increased episcleral venous pressure. So you're kind of secondarily preventing a proper outflow of aqueous. Consider thyroid disease as a mechanism, superior vena cava syndrome, CCF or carotid dural fistulas, orbital varices, and Sturge-Weber, of course, which we already talked about. The vessels, probably, yeah. Because they are very fine, kind of arborizing. They're not the thick vessels you see with like neovascular, those kind of things. So, okay, good, thank you. So on exam, people with increased EVP, you might see these tortuous dilated episcleral veins. They may have blood in Schlemm's canal on gonioscopy due to that back downstream pressure causing a reflux of blood into the canal, which normally should not have that. So, yeah, Schlemm's canal, I mean, is you can't really identify Schlemm's per se on gonio, but yeah, if you see a thin line of heme when you're doing gonio, it'll be, so it's kind of juxtacanalicular, right, is where Schlemm's canal is. So just think about if you're imagining where it runs, it's probably, it's almost, I guess, adjacent to the TM or running with the TM. Then you would consider that as maybe a sign. And I've seen this before with thyroid. So always good to check if you have someone with active thyroid eye disease, do gonioscopy, which is not something I always think of doing, especially in the setting of elevated IOP. They may have signs of ocular ischemia, venous stasis, of course, depending on what the etiology is. Exophthalmos, again, in a thyroid patient. And then the intermittent exophthalmos with orbital varix. And you would treat the patient based on what the underlying cause is. Very difficult surgically to treat these patients. You have an increased risk of choroidal effusion. You get increased risk of expulsive choroidal hemorrhage when you go into these eyes. So some people advocate doing a prophylactic posterior sclerectomy, so creating kind of scleral windows before doing any kind of filtering surgery as a way to potentially alleviate that secondary pressure against the eye wall. So you can kind of see here the distribution of in a Sturge-Weber patient of the facial angioma. And here's a pretty classic example of dilated episcleral veins. We won't see it that remarkably probably in most patients, but that's kind of what you're looking for to some degree. And okay, good. So let's move on to trauma. Everyone good so far? Sorry, I'm going fast, but I want to try to get through other topics. So here's where we can kind of start talking a little bit about angle recession. So any kind of non-penetrating or blunt injury to the anterior segment could cause a secondary glaucoma, open angle variety. So we're talking about hyphema, angle recession, which is a damage to the angle itself, and then you can see iritis, iridodialysis, cyclodialysis, traumatic cataracts or lens dislocation, and signs of trauma in the retina can all be a sign that the person had some kind of traumatic history. Early on, after an injury, you can see a rise in the IOP, but that's usually due to inflammation, secondary blood, RBCs due to hyphema, for example, and even direct injury to the TM, again, causing a swelling or edema of the TM and trabeculitis. But if you get trabecular damage at the time of trauma, you can even see glaucoma months or years down the road. So whenever you do these 6-week follow-ups where you can gonio trauma patients, make sure you're looking carefully for any subtle signs of trauma to the trabecular meshwork, and you have to warn these patients there are a lifelong increased risk for glaucoma after getting an injury like that. And chemical injuries can also cause an acute secondary glaucoma as well, especially alkali burns. So keep that in mind. Really know how to treat hyphema and what to look for because of the increased risk for glaucoma, especially after a rebleed. So the rebleed is generally somewhere between 3 to 7 days after initial hyphema. Some books or texts say 2 to 5 days, but I'd say, stay within a week is probably what you need to remember. And you get these IOP elevation spikes because the TM is obstructed, again, by these secondary inflammatory and blood components. And make sure you're doing a sickle cell panel on pretty much every patient with a TM, unless with a TM, excuse me, with a hyphema, every patient with a TM, definitely check them too. But essentially, even patients who appear Caucasian, there can be patients who have Mediterranean or African American descent who may not appear physically, look that way, but they have the tendency to often they can have sickle cell trait, and not be at all your typical patient that when you look at them, you can identify. So make sure you're doing that, especially if they're having a setting of acute IOP elevation in a hyphema, because you have to be very careful how you treat those patients versus someone who's not sickle cell or sickle cell trait. So you guys have seen plenty of these.
And thresholds for surgical intervention are much lower than sickle cell.
Exactly. So we'll talk about that. Yeah. No. So generally, you want to treat conservatively. if the hyphema is uncomplicated. The shield, head of bed elevated 30 degrees, restrict activity. If you're not sure if they can be restricted in their activity, children, uncooperative patients, then you probably need to admit them. And then you treat topically with steroids, cycloplegic agents. You could consider systemic, but that would be if you just saw a lot of inflammation. You probably don't need to do that typically. There's this questionable benefit of aminocaproic acid, and I think there's trends every few years. Specialists say, yeah, use them, then don't use them, but I don't think we necessarily go that route for most of our patients. Now, in elevated IOP, you do want to treat it acutely. Make sure you use aqueous suppressants and even hyperosmotic agents, but avoid, in your sickle cell or sickle cell trait patients, avoid carbonic anhydrase inhibitors and adrenergic agonists. Do you guys know why those are two no-nos with the sickle cell patients? Exactly. So you get this increased sickling and increased trapping of the blood cell components in the TM. So you have to make sure you're careful about that. What about the adrenergic agonists, though? Because that's the CAIs. Right. So you have these patients are at increased risk for anterior segment ischemia, right? So make sure you're not using that that class of agents either. So you're kind of limited in those patients on what you can do medically, right? So if they have a high IOP, which they're at higher risk for just being sickle cell trait or sickle cell, then you need to have, like you were mentioning, Aurea, a lower threshold maybe for surgical intervention, AC washout, to try to eliminate the cause for the IOP increase. And then you can also, because these guys are more prone to anterior segment ischemia and retinal ischemia, if you leave them with a high IOP, they could have a vaso-occlusive event. Even young, otherwise not predisposed patients to that, these guys can have that. So another reason to be more aggressive. Other traumatic glaucomas, think about hemolytic glaucoma, which again is the secondary open angle mechanism where the hemoglobin-filled macrophages block the TM. Ghost cell glaucoma, I know there's a few TDCers who float around with ghost cell glaucoma. I don't know if everyone's gotten to see those. No, maybe not. Maybe they've gotten out of the system. There was at least one or two who would always get seen every few months. So interesting to see these because you can actually visualize sometimes the khaki-colored cells that kind of float around in the AC and kind of go between the vitreous and the AC. So these, generally, it's these chronic, untreated vitreous hemorrhages. And once this develops, you just kind of have to let it pass. You don't generally go in unless there's a lot of issue with IOP elevation that you can't treat medically. Then you might have to go in and do vitrectomy and all that. But that's not generally what you do in those guys. First off. Yeah. Yeah, so hopefully we're not getting, but you never know. I mean, TDCers, they can get a vitreous hemorrhage and show up a year later because, so you be aware. You guys are more likely to see it than a lot of other residents. Surgical trauma and glaucoma. So intraocular surgeries can result in elevated IOP. The most common reason probably is in an otherwise uncomplicated surgery would be use of viscoelastics, especially the dispersive viscoelastics that just are retained in the eye, not enough thorough viscoelastic removal at the time of surgery. But generally these are absorbed within 24 hours. So you just have to ride it out and give them, medical treatment for the IOP and follow them closely, like daily, until you see it go down. IOL implantation itself can cause some secondary glaucomas. Uveitis glaucoma hyphema syndrome, which thankfully we don't see much anymore because we're not using the older version of the ACIOLs that used to cause this. But you're kind of seeing a resurgence of this with some surgeons placing a one-piece IOL in the sulcus, which is something you should avoid doing at all costs, but sometimes it happens. And because those aren't meant to sit in the sulcus, the haptics tend to rub peripherally on the iris and cause the secondary uveitis, along with the glaucoma syndrome and hyphema because of the chafing. So you still need to be aware of it. Secondary pigmentary glaucoma, if for some reason the IOL implant is, again, rubbing, disturbing the iris and causing this release of pigment into the TM. Pseudophakic pupillary block, not so common, but it's also called capsular block syndrome. And again, it usually has to do with the retained viscoelastic that's behind the IOL. And so that, again, is a temporary thing that you have to ride out. Happens more commonly when you have like a previously vitrectomized patient, for example, that you do a cataract surgery in. Their bags tend to be more floppy and difficult to deal with. You don't have the vitreous kind of keeping everything buoyant behind the lens and behind for your cataract surgery. So it's often harder to get all the viscoelastic out once you get the lens in. So just expect it more commonly in those eyes.
So that it's more of like an anterior, more pushing anterior type thing
Yes.
than it is like a reverse pupillary.
Exactly. Yeah,
Pupillary
reverse
look
pupil.
back.
No, yeah, it doesn't usually look. No, so reverse pupillary block, keep that mainly just for the pigmentary glaucoma picture. Yeah, this is kind of a. I probably shouldn't put it in technically in the secondary open angle glaucoma talk because it is more kind of a angle closure, at least a posterior pushing mechanism. Yeah.
Just like
Kind of, but the phacomorphic is the lens itself, and here it's a little different. But okay, so glaucoma post RD, again, this is something that you could see more commonly in TDC maybe, but if you get this chronic untreated rhegmatogenous RD, you can get these floating photoreceptor outer segments that are liberated with the detachment, and they float to the AC, and then they get clogged in the TM. Again, super rare, but boards and OCAPs love this, and they may just call it the Schwartz-Matsuo syndrome, so you want to make sure you know what that means. Okay, we kind of already talked about corticosteroid-induced glaucoma, but I think, unless anyone has questions about this, I think someone already asked, usually develops within a few weeks with potent steroids. Oh yeah, so I should have pointed out, with the higher potency, like the prednisolone, Durezol, those they tend to, if it's going to be an IOP spike or a corticosteroid response, it'll happen more quickly with those. And with the weaker steroids, it takes longer if they're going to develop it. Oh, and also it's important to note, because I actually have had a handful of patients over the years who were not really on any steroid to speak of, but their IOPs were kind of high, and if you take a good history, they might be on, a nasal corticosteroid for allergies, for example, and they could be on it for years, and they might develop IOP elevation from that. You'd never, if you didn't take a full history, they won't know that that's a steroid offhand. So make sure you're looking at their medications from all routes. All right. Hey, John. Consults? Oh, okay, cool. So we don't really understand the precise mechanism for TM obstruction, but we do know from rabbit studies that in people who are, or in rabbits who are steroid responders, there's a high concentration of, glucocorticoid receptors. So for some reason, that's a configuration of the TM tissue. So the target tissue looks to be that there's this remodeling of the TM, and that's what, from the steroid use, and that's what causes the decreased aqueous outflow. So in predisposed patients, they actually have that change in their configuration of their TM, which leads to the high IOP. First thing you want to do if you truly determine that it's steroid-induced is to try to discontinue the steroid. Know that the elevation takes a while to resolve, so of course you have to keep treating them medically to try to lower the IOP in the meantime. Generally speaking, for as long as they've been on it, let's say 2 months, it can take up to 2 months for the reversal. So as long as they've been on it, consider up to that amount of time that it'll take for the IOP response to go away. I'll let you read over this other information. So you may have to go in rare cases to filtering surgery if you just can't control the IOP anymore.
When Dr. Goldstein was here, I think she was kind of saying it in an overstatement format, but she said basically if she uses Durezol, she's going to end up with IOP trouble for patients.
Yeah.
Is it really that darn common? Because we're talking about then having to have underlying susceptibility.
Right.
So
that's true. I don't know. That might have been she treats a lot more uveitis than I do. Yeah, so Durezol definitely has a higher incidence of it. It's actually used as a treatment for hypotony in some patients. Try to bring their IOP up, you might throw some Durezol on there. Yeah, believe it or not. So as why that, you're right, it should be a predisposition and kind of this tendency for your TM to be remodeled to get the IOP rise, but with Durezol, it'd be interesting. Maybe we should look in something to look up. Why it is that, and I don't know if you could say that, if all of us use Durezol, are we going to get IOP spike eventually? I've seen patients. What's that?
Do we have access to that angle?
I don't know if it's available at TBC. Yeah. Okay, so this is the post-test. I think you guys know the answer now. Which one is not considered a secondary open-angle glaucoma? People who just walked in, it's a better test for you. Who goes with 1? Any hands for 2, 3? Okay, and then 4. Looks like 3 was the majority. And again, we talked about this earlier, but neovascular glaucoma is actually a secondary angle closure mechanism because you get this fibrovascular membrane proliferation that basically closes the TM mechanically when you get that that stage of, for example, diabetic disease that causes that abnormal blood vessel growth and then the secondary fibrovascular membrane. But all the others are open angle mechanisms. Okay, so that was that. I'm sorry it's kind of long, but let me throw this out here because I think on these I just had certain slides that I wanted to show you. Lens-induced angle closure. We wanted to talk about that. So I'm going to fly through this because some of this repetition. Phacolytic we talked about, lens particle. Okay, so we talked about the open angle lens-induced glaucomas in the last talk, so I want to touch on the closed angle lens-induced glaucomas now. And phacomorphic glaucoma is something that probably all of you have seen to some degree. So essentially, if a advanced cataract stays long enough in the eye, you can get this secondary angle closure by a pupillary block mechanism where the lens grows enough in size that it's actually pushing, it's growing in its AP diameter, right? So it's actually interiorly pushing and closing the angle with the growth of the cataract. So you have to look for a difference in the 2 eyes. Again, always examine the other eye. But you should see a difference in the AC depth. You should see a difference probably in the grade of cataract, most likely, and then do gonioscopy in the 2 eyes. So primary angle closure glaucoma, you should have the same angle configuration in both eyes. And this one, you should only have the narrow angle in the affected eye. You can try to treat initially with a laser iridotomy to try to relieve the pupillary block component. And then, of course, the definitive treatment is removing the cataract. But just like with phacolytic glaucoma, you want to try to make the eyes quiet and stable as possible before you go forward with the cataract surgery.
Do these people get posterior sneak?
So it depends on if they have inflammation as part of it. Generally, they're not very inflamed eyes. I think, let me see, did I mention yeah, I said a quiet eye, but I don't think they, as a rule, have a lot of inflammation. If they have a high IOP, then you can get kind of a secondary AC reaction, but most people are going to come to you pretty quick when they start getting pain from their eye, so they probably don't get a chance to develop PAS. Yeah.
So I do have another question. So these patients, we see a lot of these patients, and the discussion obviously is cataract surgery or PIA. And aside, from talking with the patient, are there any good predictors outside of past history of painful red eye that would clue you off to say, well, we need to do surgery quicker, or we can maybe just do an LPI and wait a little while? Is there a reason for going with one versus the other?
I mean, I think LPI helps to stabilize and maybe give you a little more space to remove the cataract, because what happens is you've got a narrow angle here and a shallow chamber, and going in to do a cataract surgery in a hypermature cataract with a shallow chamber is not going to be easy, right? So if you can get yourself a little more space by relieving the pupillary block with an LPI, I think it behooves you to do that. Probably lessens the risk of the cataract surgery as well. So here's an example of a before and after. You can see the slit beam, how much more space there is in the AC after successfully removing the cataract. Okay, all right. Glaucoma clinical trials. So I'm going to run through these by request. Some of you guys wanted to go over it. These are kind of just the overall summarization of the findings of these studies. So AGIS, Advanced Glaucoma Intervention Study, was done, as you can see, quite a while back. But basically the question was, in advanced primary open-angle glaucoma patients, what was the best treatment regimen to determine, to get the best outcome? So for whatever reason, they had these 2 treatment sequences.
Just to make sure I'm clear, how are we defining advanced?
Yeah, so they had a whole set of criteria. Generally, they had to have advanced visual field defects, which is either like a hemifield defect and or central fixation involvement with a certain degree of cupping. So the criteria for advanced generally are pretty similar across all the glaucoma clinical trials versus moderate versus early. So these were a standard definition, and if they fit that and they were phakic and hadn't had prior glaucoma surgery, then they could be included. So bottom line is what they found was that, again, I'm not sure why they did ALT and then TRAB twice or TRAB, ALT, TRAB, why they chose that sequence. But what they found was that Black patients responded better to getting initially ALT versus TRAB first, and whereas white patients did better with the initial TRAB. It could be that Black patients were more predisposed to inflammatory post-op course, where the blood may have scarred down and didn't work as well. We know that African American patients tend to have a higher risk of inflammation after surgery, and younger patients. So those are some risk factors. Cataract formation, of course, increased quite a bit after a TRAB. We know that it still happens. So you had to basically count on doing a cataract procedure later in these guys. And then it was interesting. They did a follow-up much more down the road in 2009 on these same patients, and they found that if the IOP fluctuated in these advanced glaucoma eyes, there was actually it was an independent predictor of progression of disease, even if they had lower baseline IOPs. If there was some evidence that the IOP bounced around, that in and of itself was a risk indicator for progression. Early manifest glaucoma trial. Again, a pretty long time ago. They had 255 patients in this study. The patients were all from Sweden. So again, you want to make sure you know your patient population in each of these studies and take that as a caveat when you're trying to extrapolate results. But they basically wanted to look at what was the effect of treatment in newly detected glaucoma if you used, they used ALT and Vitaxolol, or no treatment at all, and what happened if you just observed a newly detected glaucoma down the road versus treating. So treated patients ended up getting, decreased in half the risk of progression. And how much the IOP was lowered was actually a major factor. So that's the clinical pearl that came out of this is in this study, for every 1 millimeter that the IOP was reduced or increased from the baseline on follow-up, there was approximately a 10% concomitant risk of progression or lessened risk of progression, depending on their response. So that's an interesting thing, and that's something I think you can take when you're looking at your patients. Go ahead. Sorry.
So does this mean in 1997 it was okay to just observe glaucoma?
Yeah, it's interesting, isn't it? Because it's the same thing with the collaborative normal tension glaucoma study. We'll talk about that one. There was this whole cohort of patients that never got treatment. Yeah, the rules are different in Europe. No. Yeah. I think you'd have a harder time. You're right. I mean, I think the point is valid. I think you'd have a harder time getting this through an IRB approval at this point. We'll talk about some other, let's see. This one actually was randomized to two different kinds of treatment. So this one you wouldn't have the same issue, but we will talk about CNTGS in a second, and we'll look at that. So CIGITS, which is a collaborative initial glaucoma treatment study, this one they wanted to see, and all of this came out of this whole discussion the glaucoma community was having at that time, like, do we really need to treat? And what happens if we don't treat? There were all these clinical questions, and how much do I need to lower IOP by? These were all important questions, because before, glaucoma was just treated based on pressure. So if someone walked in with a pressure of 30, regardless of whether they had optic nerve changes, regardless of visual field, regardless of any of those criteria that we look at now, they were just treated. And if someone had lower pressure, but they had these signs of glaucoma, they may not be treated. So everyone was wondering, well, how do we know? So that's why these came out. So the question was, okay, if we do a TRAB with or without 5-FU or meds, which group comes out better? And this, again, are newly diagnosed glaucomas, so they're early. Both groups, surgery versus medical treatment, both had similar visual field losses at 5 to 9 years, but the surgery group actually had a greater loss early on in vision. So vision and quality of life was impacted negatively by the surgery group. And of course, surgery group had 2 times the rate of cataract surgery versus the medical group. So essentially, they look like they did the same whether you started with surgery or meds. So that kind of answered an important question. Like, do we need to jump to surgery in these patients? Probably not. Then we have the collaborative normal tension glaucoma study. And again, these are patients with, once they had been known to have normal tension glaucoma, they were studied, and so they had to have progression of disease with normal tension glaucoma. Relatively small group, it's 230 patients, so keep that in mind. But if you aggressively lowered IOP in these patients, the question was, are we going to help them? Their pressure's already low by measurement, so what are we doing if we aggressively treat normal tension glaucoma? So they were randomized to treatment, which was any combination of those interventions, but they had to use some combination of that to achieve a 30% IOP reduction from their baseline versus just observing these guys. So 5+ years, they primarily looked at visual field progression as an outcome measure. And what they found was aggressively lowering IOP in these patients significantly reduced visual field progression. So that helped answer that question. So clearly, we still need to treat pressure even in a normal or low tension glaucoma picture. OATS, which you guys are more familiar of, it's a little more recent, and they're still doing follow-up studies on these patients. Alec and I just talked about this recently. But essentially, then the question came, well, what about if they have super high pressures, but everything looks normal? You know, there are these ocular hypertensives, normal nerve, normal visual field, everything other than the eye pressure appears non-glaucomatous. So what do you do with these guys? So they were randomized to medical treatment or observation. The clinicians who were involved in the trial kind of had their choice of what medications to use, but basically the rule was lower the IOP. I believe their threshold was, I think, lowering it 20%. So either lower 20% or don't do anything. And the primary outcome measure was if they developed POAG in one or both eyes. So this was the criteria that they had to have a reproducible visual field deficit with an optic nerve head change. That was the sign of conversion. So what were the results? Treatment in ocular hypertensive is effective in delaying or preventing onset of POAG. And so what happened was, if you 22.5% decrease in IOP, so that means that was on average how much the IOP was reduced, was associated with a decrease in the development of POAG from 9.5 in the control group to 4.4 in the treated group. So their risk was cut in half. Sounds familiar with the other study we talked about, the SIGIS. So again, you want to be able to use this information when you're looking at patients, but you have to be careful. This is a very specific group of ocular hypertensives with no other appreciable risk factors for disease on exam. And each 1 millimeter IOP increase of the baseline for the patient's IOP, this is interesting, led to a 10% increased risk of glaucoma development. So the higher baseline IOP they had a concomitant increased risk in eventually developing glaucoma. So important things to tell your patients who are walking in who fit this clinical picture. You know, again, if you don't treat for 5 years, you're still only going to have, you know, basically out of 100 patients, only 10 will get glaucoma untreated. So that's pretty good risk. You know, you have a 90% chance of not getting glaucoma for 5 years. On the flip side, you know, if you want to cut it in half and only have a 44% chance, you know, 40% chance, then you may want to get treated. And that's a discussion you want to have with the patient. These were the risk factors for actually developing glaucoma over that time period, the people who made it to that endpoint or the outcome measure. Increased age, vertical and horizontal cup to disc ratio, a higher pattern standard deviation on the visual field, which is one of the parts of the printout that you can look at. Again, having a relatively higher IOP at baseline. And then central corneal thickness is one of the important findings that came out of OATS, which is why we measure pachymetry on people now. So a relative risk of POAG just independently with corneal thickness increased 81% for every 40 microns thinner than the baseline on the of patients here. The average was, I think, 555 in this study of corneal thickness. Now that's higher than the general population. So in studies that have been done on the general population by ultrasound pachymetry, most people are, you know, 530s. 525 to 535 probably is the range. So again, don't use 555 as your criteria for normal corneal thickness, because that was in the ocular hypertensive group. But in this study, they found for every 40 microns thinner on average from the 555, they found an increased risk of POAG. So the longer follow-up on this study found that, so the original observation group, on the longer end of the study, they received meds for 5+ years after initially not getting treated for 7+ years. And after treatment was started, there was no change in their Kaplan-Meier, the survival curves between the original treatment group and the newly treated observation group. So that means that those who are in lower risk category don't have the risk factors we talked about. Treatment of ocular hypertensive patients could be safely delayed if they don't have those risk factors on presentation. So again, more important information about maybe just needing to watch these patients versus treating. Because it's important, you don't necessarily want to buy these patients a lifetime of drops if their risk of converting is low, or at least give them the option. So we also found that African Americans had thinner corneas than Caucasian subjects in OATS, so that was interesting. And this is an article that I like to discuss with the residents on the rotation on glaucoma when you guys rotate with me. But a separate study on visual field testing through OATS found that repeat visual field testing failed to confirm abnormalities that were initially found on these reliable abnormal fields, 86%. So there could be this phenomenon of early fluctuation in glaucoma where you kind of get a smattering of abnormal and normal fields, but nothing sticks until later on in the disease. I kind of call it the flickering light bulb effect. So that may be why that's happening. Go ahead, were you going to say something?
But it's thought that actually would be a pathophysiological thing rather than the patient factor.
Yeah, so Alec and I talked about this. What do you think? I mean, that's essentially.
Yeah, they were like very reliable fields.
Mm-hmm.
So they'd get an error there'd be a field defect in the first test, and then they'd repeat it, even though it'd be reliable by like very strict reliability standards.
Mm-hmm.
That deficit could just disappear.
Has this been repeated in the population that didn't know they were being tested for glaucoma?
But it's reliable.
I don't know if you could do that. Yeah. I don't know how you could finish. Yeah. I don't think it has been done.
It's like, it was like 3,000.
Yeah, this was actually a very big study. Some of these are small, but this had thousands of patients.
Maybe it's the first time I have visual fields. Because I already know how to use a visual field and take it.
Yeah. Yeah, everyone probably came in with a little bit different set of experiences with taking the visual fields, but they had to do a lot of fields while they were in the test. And that's
like 3 initials, like
Yeah.
just to get into this.
Yes.
1 and then 2 and then
yeah. So by the time they're getting the data analyzed, they're pretty good at taking the test. Yeah. Other possible associations with POAG that have been seen from other trials. There's this soft association with myopia and diabetes, but neither of those were seen in OATS. Again, hypertension sometimes comes up. Systemic hypertension, systemic hypotension have been linked to glaucoma in different studies, but that's, again, questionable. Okay, tube versus trab study, tube versus trabeculectomy, TVT. This, again, is a little more recent study. It's multi-center, randomized. It was a prospective trial to compare interchamber tube shunt placement with trabeculectomy using mitomycin. And so it was about 212 eyes, and it was randomized which treatment you got, and they used the Bayer-Velt 350 in this study. And so it looked like, in fact, at 5 years, the tube shunt surgery actually had a higher success rate, but with a similar IOP reduction. The rate of failure was higher in the trab group, as well as needing additional glaucoma surgery. That was higher in the trab group. So you might look at this and say, well, why doesn't everyone do tubes first? I think clinical habits die hard. I think trabeculectomy is probably going to stay as the primary glaucoma surgery for the foreseeable future. And there's actually benefits to doing, in the right patients, doing trabs first. I mean, I think they can have very solid outcomes. And the good thing about doing a trab first, essentially you have more real estate in the eye to do tube placement. If you start with a tube, it's less likely that you're going to be able to do a successful trab because you induce some level of conjunctival scarring when you go in to do the tube surgery in the first place, and that's going to make your subsequent trab surgery harder. Whereas the flip side, it's not going to really affect the tube outcome to have had a prior trab in the eye. So I think trab's probably still going to remain as the primary surgery. before a tube. But in certain populations, for example, TDC populations, for a while back, a few years ago, I started actually having the residents do primary tubes in a lot of those patients because the follow-up is so notoriously poor. Patients may not get their Pred Forte drops for the first month after surgery, and then they show up and they've got a scarred down trab. So tube surgery is a lot more forgiving in the post-op period. You can generally keep a pretty well-functioning shunt even with minimal post-op care. Trauma-wise as well, I think, sorry, I don't know why I put all these silly, okay, I was in a goofy mood. I was saying, oh, with patients at higher risk for trauma, you know, I think they will probably be safer with a tube than a trab in the eye in terms of potential extraocular, you know, manifestation of eye on cheek from blunt trauma. The risk is a little bit less with a tube versus a trab. And we're getting really late, so we don't need to go into this lecture, but I had a little bit about angle closure glaucoma, not a little bit, a lot about angle closure glaucomas, but we can talk about that on another day. And I'll keep the lecture available through the Blackboard, so if you guys want to go back and look at stuff, if you want to look through angle closure glaucomas and ask me questions about it, but we can just cover it in a later lecture too. Yes?
I found a lot of times the studies seem to run together. Could you pick up that for kind of keeping them separate? Because they like to ask you, a lot of times the answer choices fit with one different study, and so one answer choice will fit with that study, and the other three will be similar studies.
Yeah, so I mean, I would say I kind of pulled what I put here from, you have some like little, they're like these little summary things, yeah, and so I pulled from that. They're kind of just, I don't know why they gave them such hard names and kind of weird, it doesn't make sense to me, but I would say do like flashcards or something and just kind of memorize a couple of key findings, you know, what's listed here, go back to this lecture and just literally say, okay, what is the most important clinical recommendation that came out of that study? Hopefully they're not going to ask you the minutia. I mean, I think it's generally they ask you the overall. Okay,
Yeah,
they probably do ask the
Last
minutia.
year,
Really?
they asked you something
Like how?
in PCSC, actually, that was what was controversial.
What did they ask?
Yeah, something that was from the paper
Uh-huh.
itself. That was
Oh, but it's not. Oh, interesting. That doesn't seem fair.
Which the following glaucoma population was included in such and such study. I think it was for the EMGT.
Mhm.
If I remember, it was a Swedish population who were telling me that the answer was Sudox, but I didn't realize it was Swedish patients at the time.
Oh God. So that is minutia, kind of.
Yeah, it really was. It was not
You
what
know,
I
sometimes they
expected.
throw in these experimental questions that don't end up counting towards your actual grade. I would hope that those kind of are, I'm guessing, but that doesn't seem like necessarily fair, anything's fair game, but it doesn't seem like a fair question. I mean, I think knowing the major clinical outcomes, the things that change kind of practice is what you need to know for these. Don't quote me on that. I know, I'm sorry. Well, memorize what you can, minutia-wise. I wish I had a good answer for you, Elise.
I think that's
Other
one
than-
area where I find between glaucoma and retina, it's just like you kind of fall down flat on your face.
Yeah.